Hello, good afternoon, and welcome. My name is Susan Lynch. I am the Associate Director of Lifetime Learning at the University of Virginia's Office of Engagement. I'm so pleased that you are joining us this afternoon to learn about the latest in the detection and treatment of lung cancer. I want to thank my colleagues at the UVA Cancer Center for their partnership with today's program. Before we start, I want to bring a few things to your attention. We received many questions in advance of the program that have been shared with the speakers. If you have a question during the presentation, you may enter it in the webinar Q&A at the bottom of the screen. You'll find resources in the webinar chat box below. Please also note this program is being recorded and will be posted in Lifetime Learning's podcast library in about a week or two. We are fortunate to have four very distinguished clinicians with us this afternoon, all from the University of Virginia Health System: Aimee Strong, Linda Martin, Richard Hall, and Ryan Gentzler. Each speaker will introduce themselves and pass the program on to the next presenter. We'll share a document in the chat box with more detailed bios for each speaker. Dr. Gentzler will be moderating a Q&A with the panel after the presentation. So with all that said, thank you again for joining us. And Aimee Strong will start us off. So Aimee, I invite you to start your presentation.
Good afternoon, everyone. I'm so excited to get to talk to you all today. I'm going to share my screen here. Okay, so I'm Aimee Strong. I'm a nurse practitioner in thoracic surgery at UVA and also run our lung cancer screening program. I'm excited to get to share with you guys some updated information and maybe some basic information about lung cancer screening. So we know that lung cancer is certainly a deadly disease. It is the second most common cancer in both men and women, but it's the leading cause of cancer-related deaths. It makes up about 1 in 5 of all cancer deaths. And in 2024, we're expecting over 234,000 new cases and 125,000 deaths. Those numbers over the years are getting a little bit lower. Some of that is because we are doing a better job at screening, and we also have many new treatments that you guys are going to get to hear about today. The graphic on the left just is to bring to the forefront of your mind something you may not be familiar with. Lung cancer actually kills more people than breast cancer, prostate cancer, colon cancer, and melanoma combined. So what are the risk factors of lung cancer? There are lots of risk factors, and there's risk factors that we don't even understand yet. But the biggest risk factor and thing that's associated with lung cancer is smoking. About 80 to 90% of all lung cancer cases are associated with smoking, and smokers are at about a 20-fold higher relative risk for developing lung cancer in their life. But there are other things that contribute to the development of lung cancer. What you may not know is the second leading cause of lung cancer in the United States is radon gas exposure. And this is something that's a naturally occurring gas in the soil and bedrock. It seeps into our basements and we can breathe that, and over time that can lead to the development of lung cancer. Secondhand smoke exposure certainly is a risk factor for lung cancer. And age, as we all get older, we're at a little bit more risk for developing cancer. There's also exposure to other cancer-causing agents, things like asbestos, uranium, diesel exhaust, silica, toluene, and benzene gases. So there's a lot of things that contribute to the development of lung cancer. Plus, we have our own genetic makeup that can contribute to it. So it's not just one thing, it may be a combination of many things. This graphic's really busy, but if you look to the right side of your screen, you'll see that the 5-year survival rate for lung cancer is really low at about 17.8% compared to breast and prostate cancer, which fortunately have a really high 5-year survival rate of like 90 and 99%. And then the graphic on your left side of your screen shows the stage at diagnosis and the corresponding 5-year survival rate. So that navy blue 27% shows that only about 27% of people are found to have lung cancer in its earliest stages, when the 5-year survival rate is the highest at about 63%. Then if you look more towards that green chartreusey color, these are the later stage lung cancers. And the majority of lung cancers are found in those later stages. About 4 to 50%, and the corresponding 5-year survival rates for those are really low at 8 and 15%. So if we can find lung cancer early, when it's in that stage 1, it's often much more easily treatable. So, what is screening for lung cancer? Well, screening in general means that we're looking for a disease or a problem that may exist before a patient would ever have symptoms or history of having that disease. So, lung cancer screening is very similar to breast cancer screening with mammograms, colon cancer screening with colonoscopy. Now we do CT scans of the chest for lung cancer screening. And our goal with any screening test is to find it early when treatments may work better and we can potentially cure this. So for lung cancer, the only recommended screening test is a low dose CT scan of the chest. We call those LDCTs. And it's a simple, quick, easy CT scan. There are no needles in people's veins. There are no dyes or contrast. It literally takes 10 seconds to get the CT scans. We used to use chest x-ray because that's really all that we had, but we have data now that shows us that CT scans are much better. And this is just for your future reference. There are many randomized controlled research trials that have been performed both in the United States and around the world that show that using a CT scan instead of chest x-ray is far better than just plain old chest x-ray. So there's lots of data now. This isn't something new. These trials were published several years ago in 2011, and then there's much more recent trials. So the data is strong to recommend that we do screening. So who's eligible for lung cancer screening? Well, it depends. There are varying guidelines out there. There are guidelines based on insurance coverage. So, in my mind, when I'm talking to people who are interested in lung cancer screening, we have to make sure that they're eligible based on what their insurance coverage is. So, we've got 3 big categories here. We have commercial insurance, which is everyone other than Medicare. And then the middle column shows what the Medicare guidelines are. And then we'll talk about the right-hand column, which are the new American Cancer Society guidelines. So first of all, let's look at this column here with the United States Preventative Services Task Force recommendations. This is what your commercial insurance plans are going to cover. This is not a Medicare population. This is people with Anthem and other commercial insurances. There's an age requirement. The age requirement for commercial plans is ages 50 to 80. We don't screen people younger than that because the data doesn't support that at this time. And we don't screen people over the age of 80 because the data isn't strong in that population. So to be eligible, you should be between the ages of 50 and 80. You have to be a current smoker or someone who has quit in the last 15 years. Then you'll hear us talk about PAC years and PAC year eligibility. That means basically a calculation that tells us how much you've smoked over your lifetime. If you've smoked a pack a day for 30 years, that's a 30 pack year history. If you smoked half a pack a day for 50 years, that's a 25-year pack year history. So from a medical provider standpoint, we're always thinking about what's the total volume that people have smoked over the years. And I mean, I'll be very honest and say that in my experience, people of my generation and older have usually smoked enough to qualify for lung cancer screening, because most of the time we've started smoking when we were in our teens and smoked over an entire lifetime. So most people have had that amount of cigarette use over the years. So you have to be the right age, you have to have smoked enough to qualify, you have to be a current smoker or have quit in the last 15 years, and you have to be pretty healthy and not having any worrisome signs for lung cancer. So what's a worrisome sign for lung cancer? That could be scary things like coughing up blood. It could be a new cough that doesn't go away, or new shortness of breath or pain when you breathe or cough, losing a lot of weight without meaning to. Those are signs that you may not need to be screened, but you may need to talk to your doctor about other things. So those are the guidelines for commercially insured. And then the middle column shows the Medicare guidelines. They're exactly the same, except Medicare cuts off lung cancer screening at age 77. That's a very arbitrary number, and it was based on one of the clinical trials. We expect that in the next few years, Medicare is going to go up to age 80. But right now, ages 50 to 77, smoked a good amount over the lifetime, current smoker, or recently quit. And then in the third column, the American Cancer Society put out new guidelines about a year ago where they agreed with the age. They said, yeah, 50 to 80. Yeah, 20-pack year smoking history, current smoker, but they got rid of that 15-year cutoff. And that's a big deal because that also was an arbitrary piece of data from one of the clinical trials. There's no data that really supports that your lung cancer risk goes away after it's been 15 years since you quit smoking. So I think that in the next few years, we're going to see Medicare and commercial insurance plans move over to the new guidelines. But right now, that's just a suggested guideline from the American Cancer Society. So you can see how confusing it is for both patients and providers to know who's eligible for lung cancer screening because there's so many different guidelines. So what do we find on these CT scans? Remember, it's an easy scan. When it comes to cancer screening, lung cancer screening is about the easiest thing we can do to you. We might find a little nodule or a little spot in your lung. If it's really small, we don't get too excited, but we do those scans once a year to make sure that little spots aren't growing and that no new ones are popping up. Sometimes we'll see something that catches our eye and we just want to watch it closely. So you might get a scan in 3 months or 6 months. If we're really worried about something that we see on a lung cancer screening scan, we're going to jump right on it and move on to more of a workup with maybe a fancier type of scan called a PET scan, perhaps a biopsy, or a referral to come see one of the pulmonologists or thoracic surgeons to talk about what to do next. We also will find things on the CT scans that we weren't really looking for, and that's good and bad. We might find another cancer in another organ that we didn't even know existed, and we can intervene on that. We might see severe calcium buildup in your heart arteries that we need to intervene on. Or we can even see your bones to see if you have osteoporosis or not. So there's good and bad things that we can also see on these CT scans. There's some risks that come with screening, and this is why we don't screen people outside of those recommended guidelines, because even though CT scans are safe, we may find something that is very concerning for a cancer that turns out to not be a cancer, and that's called a false positive. It may lead to additional tests, biopsies, or even surgery sometimes to find that this actually may not be a cancer. And there's radon exposure that comes with lung cancer screening too. So we do follow very specific guidelines, depending on your insurance, ages 50 to 80, current smoker or quit in the last 15 years, 20-pack year history, and overall healthy. So in conclusion, lung cancer screening should be done for patients that are eligible, because if we find an early stage lung cancer, we can often cure it with treatment. And that's my time, and I'm happy to hand this over to my colleague, Dr. Linda Martin, who is the Chief of Thoracic Surgery here at UVA.
Well, thank you so much, Aimee. That was some great information. I'm going to get my screen ready to share here. Again, thank you for joining us this afternoon. I'm going to take it to the next step and talk a little bit more about going from screening and looking for nodules to what if we're starting to talk about an actual diagnosis of lung cancer and what are some of the options. And some of what I'm going to say may overlap a little bit with Aimee, but it probably helps just to hear it in a couple different ways. So just going back to lung cancer risk factors, and this might address some of the questions coming up in the chat as well. So definitely we know smoking is a risk factor. either current or former smokers, and it probably attributes to about 80% of lung cancer diagnoses these days. But there's other factors we're learning about. So genetics are more of a factor. At one point, we didn't think that family history really mattered, but we do think there is some component of family history that may contribute. Age is a factor, something none of us can avoid, but the older we get, the more our risk is of cells changing and developing cancer in basically all areas of our body. Radiation exposure is an issue. For example, if you've had prior chest radiation from another diagnosis, that might change your risk, but also certain areas of the world where they've been exposed to radiation from nuclear bombs and so forth is a factor. There's some occupational hazards such as coal mining. Radon gas is one that I think is likely related to a lot of non-smokers developing lung cancer, and that's something you can test for in your home and may come up during any sort of home inspection when you're buying or selling property. And then pollution is a factor, and I think in our part of the world, that's not as big of an issue. Some places where there's a lot of indoor cooking with coal or wood burning stoves, that may be more of a factor. Firefighters, there's definitely some exposure there to who knows what they're breathing, and so there's been some interest in looking more closely at firefighters and screening them more heavily outside of the guidelines that Aimee just talked about. And then asbestos is another one we often think about with a tumor called mesothelioma, but in fact, it is a risk factor for lung cancer also. Again, reiterating some statistics that Aimee just mentioned. These are on the top, new cases and how often they happen in men and women, and on the bottom are people dying from cancer diagnosis. And just to reiterate that we do see a lot more people dying from lung cancer than we do from other cancer diagnoses. However, it is getting better, and I'm going to show you some numbers to substantiate that. So this is from the same statistical paper that comes out year after year. And it shows that in red that the lung cancer new cases is really been dropping down nicely, specifically in men, but it's starting to drop down in women as well. And I think that just reflects the lag in women adopting smoking and then getting into smoking cessation. And then you can see on the far right, the death rates from lung cancer are not great, but they are definitely improving and getting better year after year. So it has changed in my career from about a 10 to 15% 5-year survival to now the latest statistic is 25% 5-year survival. So it really has jumped up quite a lot. So diagnosis, okay, let's say you go through screening or you have a scan for some other reason and a nodule is detected. On the left-hand side is an example of what a CT scan might look like. And you can see the arrows pointing to this white spot with kind of an irregular shaggy margin. And that's a suspicious finding for a lung cancer. And from there, if that is the result of a CT scan, usually we're going to talk about something called a PET scan to evaluate that further. Sometimes that will be called colloquially a cancer scan. And it's a test to look at the metabolism of that nodule in the lung and see if it's glowing or lighting up like you see over here on the far right. And then there's many different ways to do biopsies, but more and more often we're having our patients get biopsied with a procedure called bronchoscopy with a camera down inside of the airways. And then biopsies can be taken of the spot in the lung and sometimes also to check lymph nodes in the area to find out if lymph nodes may or may not be involved. And that moves into the next thing, which is staging. And that term is thrown around a lot, but I want to make sure everyone has a handle on what that means. The stage is a way for us to just put people into categories as far as how aggressive or advanced a cancer may be at the time of diagnosis. And the reason that this is important is, of course, it helps get to that question of prognosis. How long do I have? Is this something I can beat? That sort of thing. But it also gives us an idea of what sort of treatments are best suited to that person's stage of cancer. And are we being aggressive enough or not aggressive enough depending on the stage? So just moving from left to right, stage 1 is typically going to be a solitary nodule within the lung without any lymph node involvement and relatively small in size. When we get into stage 2, we're starting to see lymph nodes adjacent to the tumor involved, but still contained within the lung. Stage 3 is where the lymph nodes are more in the center part of the chest, also called the mediastinum, which is just a fancy word for in the middle. And then stage 4 is when we may see cancer cells outside of the chest cavity. So for example, in the liver or the bones, the brain, other areas of the body where we think cancer cells have traveled in the bloodstream to get to other areas. And here's just a quick overview of how we adjust our treatment based on the stage. And you don't need to know all this in detail, but it's just to give you an example of how we alter our strategies depending on the extent of disease. So in stage 1, we're going to use something like surgery most of the time. And in some cases, in patients who are maybe more elderly or frail, or have significant lung disease, we might use a focused type of radiation called SBRT. And as we move from left to right on the screen, we added more therapies because we need to be more aggressive with the disease. So once it's in lymph nodes, we add in chemotherapy, or sometimes we'll switch to chemo and radiation. Stage 3, again, we add in more therapies tailored to the individual, to their tumor genetics and so forth. And as we get to stage 4, we're usually not going to be using surgery, but using other treatments like chemotherapy and some of these newer drugs called immune therapy or targeted therapy that you're going to hear more about later in this presentation. So what about surgery? What does that entail? That is my particular area of expertise. And just to give you familiarity with these terms, there's a couple of different ways we can use to get inside the chest to take these tumors out. And there's no right or wrong way to do this, but it does depend on the surgeon's expertise and experience, but it also depends a lot on the individual patient, and also where is their tumor, how big is it, how involved is it, because in many cases that you may have to adjust our techniques for that situation. So on the far left is our more traditional type of surgery where we make an incision in between the ribs. And this is how we get directly in to get to the tumor. I still do this surgery quite a lot, but most often in the situation of a very large tumor or where it's attached to vessels or lymph nodes and things like that. And then there's another technique called VATS, which is video assisted thoracic surgery. This is a minimally invasive surgery. And this has been around now for a couple of decades with these long, skinny instruments, kind of like we've used for gallbladders and so forth. And more recently, there's been sort of an adjustment of the VATS technique, and now we'll use what's called robotic surgery with the Da Vinci robot. And that's where we're using small little entry points, but it's being operated by this much more sophisticated machinery. And it lets us move the instruments in a more natural way, almost like our own wrist would move, where it kind of floats around and articulates in a much more elegant manner and lets us work in a more natural way. All of them have good results. There's not a right or wrong here. I'm just familiarizing you with the terms. And then the last thing I want to touch base about is some innovations in surgery where we're looking at making the surgery easier on people and helping them get on to the next phases of either their treatment or their lives. And the thought is to say, can we help you go from feeling like a patient to feeling like a person as soon as possible, and help you not only recover quickly, but also recover well, where we optimize pain control, but minimize things like opioids and narcotics that tend to make people feel nauseous, constipated, and sleepy. So we're still treating pain, but we're treating it in a way that is less disruptive to your functioning. We've minimized the time that people are in a fasting state and can't eat or drink. We try to get people up and moving around, take their drains out, get them out of the hospital faster. And really, in my mind, one of the most important things about this is getting people through this phase of surgery, because they may need these other treatments you're going to hear about from Dr. Gentzler and Dr. Hall. And if we delay their surgical recovery and they can't get onto those treatments, that may really affect how successful the treatment will be ultimately. And that's something that we've innovated here at UVA, and many sites around the country are doing it, but I think we are the most active in this approach here at UVA in the entire state of Virginia. Here are a couple of websites with more information that you might find helpful. Some patient-facing information from one of my societies, and it's, if you look up CT surgery or cardiothoracic surgery patients.org, there's all kinds of great resources about heart and lung surgery. And then more information about that fast or enhanced recovery is listed here. And then there's some really great websites out there about lung cancer education, advocacy, and pretty much everything we're talking about will be on there in some way, shape, or form on the Go-To Foundation for Lung Cancer. I thank you so much for your attention and for your interest in this topic. And I just want to leave you with the idea that as bad as the statistics have been in the past, things are really getting better, and there's so much reason for hope and for pursuing treatments, and even more importantly, screening to identify things early. Thank you so much. Our next speaker is Dr. Richard Hall, I think. Yes, there he is, ready
Yes.
to go. And he
Thank
is one of my
you.
oncology colleagues. He'll talk to you about his area of practice.
Great. Thank you so much, Dr. Martin. That was a really wonderful talk, and I loved your final points there about there is reason to have hope about the treatment of lung cancer. And so I'm going to begin here talking about some broad advances in lung cancer therapy. So I'm an associate professor of medicine at the University of Virginia, and my job is primarily in medical treatments, which are, as you'll see here in a bit, there's quite a few that we offer patients based on various factors related to their cancer. So I won't belabor this too much. Dr. Martin did a nice job showing sort of that lung cancer rates and survival lung cancer rates are going down, survival is improving. Aimee covered some of the risk factors for lung cancer very thoroughly. I will just say there has been some recent studies that show that lung cancer rates have started to increase in female never smokers, and that's a global phenomenon that we're not entirely sure why that is. But there are many kinds of lung cancer. So this is a very, probably a bit of an oversimplified version of the various types of lung cancer. We've talked a bit broadly so far, but there are really two main types, non-small cell and small cell. And you see kind of the percentages. This is sort of based on some US data on the estimated percentages of the two primary types, where small cells on the left, the little pie kind of out. The remainder of the types of cancer that we see are non-small cell, but there are different kinds of non-small cell lung cancer. And so our treatments really depend on the specific type of cancer that a patient might have. But then it gets even more complicated than that pretty quickly. This is a very simple way that I think about how you figure out treatment in lung cancer. The first thing you need to know is the type. What kind of lung cancer are you dealing with? Is it non-small cell? Is it small cell? Within non-small cell, there are different types. We saw that on the prior slide. But then even more specific than that, there are many types of mutations that develop in the tumor that really dictate our types of treatment. So those are kind of things that I think about when asking the question, what kind of lung cancer a patient has. Then the next thing you have to know is, where is it? And Dr. Martin had a really nice figure that showed staging. So we use CT scans, PET scans, MRIs of the brain at times, where we try to identify, and really as best we can, the stage. We still need today, though, a tissue diagnosis. We can do some things via blood, where we take patients small blood sample to determine maybe some factors about their tumor, but ultimately we still need a tissue diagnosis. Sometimes that means a lymph node biopsy. Sometimes that means a biopsy of the lung or another part of the body. Another thing I think about when we look at where is it is how good are patients' lung function. So if I'm going to collaborate with Dr. Martin, I want to know how well they can breathe. And I think that's another part that we have to think about, especially if we're thinking about surgery. But ultimately, our types of treatment, there's really quite a few, and Dr. Martin went through some of these. I kind of break them down into two big categories. There's local treatments, and then there are systemic treatments. So a local treatment would be removing a tumor from the lung. That would be through surgery. Sometimes if a patient's lung function won't allow it, maybe we have to use a radiation type of therapy that's delivered from outside of the body into the lungs. But then there are systemic therapies. So these are therapies that patients either take sometimes by mouth, many times through an infusion, rarely through an injection under the skin, where we're giving a treatment that's going all throughout the body. And so we'll go into some of those details in a bit. So If you kind of go in this schematic from kind of in a clockwise fashion from surgery, radiation, then sometimes we even think about giving chemotherapy and immune therapy before surgery. Sometimes we will do surgery and then we will give chemotherapy and an oral therapy or a targeted therapy after surgery. If a patient cannot undergo surgery, maybe their tumor is more advanced in their chest, we might give combinations of chemotherapy and radiation, then an immune therapy. And then lastly, a lot of what Dr. Gentzler and I do is we're figuring out how to give either immunotherapy, chemotherapy and immunotherapy, targeted therapies, and other treatments to fight lung cancer. So it gets pretty complicated pretty quickly. Now, when you look at different targeted therapies for what we call oncogene-driven or mutation-positive lung cancers, that I would never expect you to know anything on this slide. The real point here is to show that it gets really complicated really quickly. And there are many therapies all kind of on the outside of this pie chart with arrows pointing in at specific gene mutations that can be present in the lung cancer. Usually these mutations, almost always, these mutations are present only in the tumor. They're not a part of a person's normal rest of their body. So they didn't come from mom or dad or get passed to kids. They develop in the cancer specifically. But we have a lot of pill, sometimes other infusion therapies that we give specific to the mutations of the tumor. So that's a really important part of our treatment in lung cancer that has really been revolutionized since I've been in practice, which is only just over 10 years ago. And almost all of these medicines did not exist when I started, which is pretty incredible to think about. Another important part of our treatment of lung cancer are what we call immune checkpoint inhibitors. Another term for this is immunotherapy, where we are helping the immune system attack the tumor. What a lot of this figure, really, if you just focus on the center, you have on the left and round a T cell, and then kind of a new, angry shaped cell that's supposed to be a target cell, most likely a tumor. But we use antibody medicines to bind to either proteins on T cells or proteins on target cells, usually tumor cells. And basically what these medicines do is as protein antibodies, they block certain functions of these proteins on the outside of the cells, and then they allow the immune system to go and attack the tumor. So this has been a sophisticated therapy that's really grown quite a bit. As you see just in the orange squares, you have a number of different immune checkpoint inhibitors that we commonly use to treat lung cancer. But this even gets a bit more complicated in that we have increasingly medicines that are called antibody drug conjugates. These are approved currently only in a few types of or actually only really one type of lung cancer currently, but there are quite a few that are in development where an antibody medicine delivers another therapy, usually a chemotherapy, specifically to a cancer cell. So in this example, a molecule called trastuzumab deruxtecan in orange is binding to a protein and is delivering the little orange dots into the cancer cell. And then this eventually leads to the delivery of this chemotherapy molecule, which kills the cancer cell. So a really sophisticated therapy that's in development for specific types of lung cancer patients. And then here I'll show a fairly new therapy. This was just approved in May of 2024. We were a part of a study looking at this therapy called a BiTE, a bispecific T-cell engager. What this therapy does is it's somewhat similar to those immunotherapy medicines, but different. It's an antibody with two parts. So one part binds to a tumor cell, and then another part binds to a T cell, a different kind of T cell than some of the other immunotherapy medicines you saw. And what that then does is brings these T cells together where they can attack the tumor. And this therapy called tarlatamab, produced by Amgen, binds to in orange a T cell, in blue a small cell lung cancer, and brings these together and hopefully activates that tumor or activates the T cell, sorry, so that the T cell can go and attack the tumor. And this has been approved in patients who have received chemotherapy and an immune checkpoint inhibitor as their first line of therapy in small cell lung cancer and advanced small cell lung cancer, and then their tumor grows despite that therapy. And so this has been a therapy that we've been involved in giving a number of patients here at UVA. I think if I leave you with a couple of key messages, I think I would tell you that lung cancer, it's a common type of cancer. It's the second most common type of cancer in men and women. But determining the best treatment is there's a lot of nuance there and can be complicated. I think it's very important to ask any physician that you see about tumor genomic testing, even if it's in an early stage, because this helps myself, Dr. Gentzler, Dr. Martin, and our other surgical colleagues figure out the best type of treatment. So even if it's early stage, or certainly if it's more advanced, you want to know about the genomic genomic mutations in your tumor. And as you saw, I just gave you a real smattering of the many different treatment options that are available depending upon the type of lung cancer, the stage, and the genomics of the lung cancer. So thank you so much for being here this afternoon. I'm going to turn it over to my colleague, Dr. Gentzler, who's going to give you some more details to talk about with lung cancer treatment.
All right, thank you very much, Rick. It was a great overview of all of the wonderful treatments we have and how these drugs actually work. I'm going to tell you a little bit about some of the research that we do here, specifically in clinical trials, and how clinical trials can translate into really advanced treatments for patients with lung cancer. But first, what are important about clinical trials? Why does this matter for patients? Why does this matter for us as oncologists and specifically for cancer centers? Well, clinical trials are the way that we get new treatments available. All of the treatments that we use today that we consider standard of care were at one time part of a clinical trial, and the patients who enroll in those clinical trials and receive those treatments are getting those in many cases years before they become available to the general public under FDA approvals. We also have a large team that takes care of patients on clinical trials, including clinical research coordinators, pharmacists, nurses, and there's a lot of extra vigilance and oversight that come into the delivery of care under the context of a clinical trial protocol. And so sometimes patients feel comforted that they have a larger team taking care of them and double, triple checking everything. And then finally, this is a graphic on the right from the Lung Cancer Research Foundation and what patients have given feedback about this. But many patients feel that by participating in clinical research, that they're contributing to something larger than themselves and helping patients in the future. This is a paper just published a few months ago in the Journal of Clinical Oncology looking at how often patients participate in cancer research. And you can see that the numbers are pretty low here. So only about 7% of patients enroll in treatment trials. A little bit larger number participate in biobanking or registry studies that collect data on an ongoing basis, and a larger number of patients. And then small numbers participate in other types of trials that look at quality of life and diagnostic type trials. A lot of this work in the United States is undertaken by NCI designated comprehensive cancer centers. UVA is one of them. And you can see that, these dark blue bars, higher than others, but this is really a group effort, and clinical trial research and other research takes place in community cancer programs and other academic cancer centers as well. And so many people are involved. When Dr. Hall and I joined UVA, one of our goals was to increase the breadth and number of trials that we have for our patients so that we have access to new and cutting-edge treatments for many different types of lung cancers and stages of lung cancer. And you can see that over the years, we've been able to provide access for more and more patients. And I think this year we're up to about 32 or 33 so far in 2024 that have enrolled in clinical trials. So more than 2 patients a month that are participating in our therapeutic trials that are testing new ways of treating cancer. Dr. Hall talked to you about biomarker testing and the importance of looking at mutations and matching treatments with those mutations. This is just a little bit of data that we've collected here over the last 8 or so years of how well we're doing as an institution for testing for these biomarkers. And we specifically were interested in early stage cancers because the treatment landscape has changed and this has become more and more important. And I think we're all proud to say that we've done a pretty good job of testing for mutations in this group of patients, with over 90% of patients getting these results. And the important thing is that we do this testing in-house and can turn this around pretty quickly. And we found that about 17 days was the average time from a biopsy to getting the testing results, which may sound like a long time, but this is actually pretty quick turnaround and allows us to identify which patients can get the appropriate therapy. I'll show you a couple of quick examples of clinical trials that we've participated and enrolled patients on here at UVA, and some of the changes to standard of care that have come about as a result of those trials. Dr. Hall showed you a pie chart earlier with the different mutation types in lung cancer. One of the more common ones is something called EGFR mutations. And we've known about these since about 2004 and have had various drugs over the years. And the current standard since at least 2018 for patients with more advanced stages of EGFR mutant lung cancer is to treat with this drug called osimertinib, which is an oral tyrosine kinase inhibitor. The paper New England Journal is shown on the left. And this has been more effective than previous treatments and is a very well-tolerated therapy. Unfortunately, at some point, cancer can develop resistance and this drug is no longer effective. And the pie chart on the right shows what happens at the biologic level that causes osimertinib to become less effective. And you can see there's a wide range of different mutations and gene amplifications that can occur. One of the most common is something called a MET amplification in approximately 8 to 17%. There are drugs that have been developed to target MET specifically, and one drug of interest that also has EGFR targeting is a drug called amivantamab. This is a bispecific antibody that has one arm that targets EGFR and one arm that targets MET. And this can cause cell death and cell degradation through various mechanisms, including binding the ligand itself, causing the receptor for EGFR or for MET to be degraded and no longer functional. And there's some immune aspect of this by attaching the antibody to the cell surface that can attract immune cells and cause cell destruction. So this drug has been tested in a phase 3 clinical trial called the MARIPOSA-2 trial. And not to get too much into the weeds of details here, but this was a trial for patients who had been on osimertinib, have an EGFR mutation, and the cancer had grown. And this was a 3-arm trial randomized to these 3 treatment arms you can see here, with chemotherapy in the gray bar in the middle, representing the previous standard of care after osimertinib. And we'll focus on the bottom bar, which adds amivantamab with chemotherapy. And these are the primary results from the trial that showed by adding amivantamab, there was a 52% reduced risk of progression or death. And you can see these curves here. These are what we call survival curves. The higher the curve, the longer the treatments are working. And you can see that blue line clearly above the gray line here with chemotherapy alone. As a result of these data, the FDA approved this combination therapy in September, just a few months ago. One of the other areas that Dr. Hall talked about was checkpoint inhibitor immune therapy, drugs that target PD-1 or PD-L1. And one of the main changes over the last decade or so is the use of these drugs, but also the use of these in combination with chemotherapy. We've been able to participate in at least 3 trials that combine chemotherapy with immunotherapy in patients with advanced or stage 4 lung cancer. The graph I'm showing you here is from a trial called the Keynote 189 trial. This is a phase 3 trial that Dr. Hall led at UVA. And the results here show 5-year follow-up from this trial. And while these numbers may not look remarkable, there's about a 40% improvement in overall survival over the old standard. And these immunotherapy drugs have helped people live longer and control the cancer for longer. But we think increase the cure rate, which is something that was previously unthinkable in a stage 4 setting. Because of the success of immunotherapy in the stage 4 and stage 3 lung cancer space, we've now thought about moving immunotherapy earlier into surgically resectable early stage lung cancer. And this graphic here represents our current standard, or previous standard, I'm sorry, of surgery first. Some patients may need chemotherapy after surgery, and then some of those patients are cured with that treatment, and some are not and have a later recurrence and undergo further treatment at the time of recurrence. There have now been a whole slew of clinical trials that have incorporated immunotherapy either after chemotherapy, as you can see in this the second bar here, or as a neoadjuvant approach, giving chemotherapy and immunotherapy before surgery, and then potentially more immunotherapy after surgery. One example of this is a trial called the Keynote 671 trial. A lot of words and details here, but just to briefly summarize, this was a trial for patients with stage 2 or 3 surgically resectable lung cancer. And they were randomized to chemotherapy alone on the bottom, or chemotherapy plus pembrolizumab, which is a PD-1 inhibitor. They then went to surgery and then had additional pembrolizumab after surgery. And the results from this trial showed that those who had received the immunotherapy had a much better event-free survival, meaning low recurrence of the cancer and continuing to live, versus the chemotherapy alone. And not just event-free survival, but also overall survival is improved with this regimen, indicating that using this immune therapy in the perioperative setting with surgery improved overall survival. And this was also FDA approved about a year ago in October 2023. Dr. Martin led a study similar to this one, but specifically for patients with stage 3 lung cancer. And she presented these results a few months ago at our World Lung Conference. And you can see just from this graphic here that those who had N2 positive lymph nodes, these are lymph nodes in the center part of the chest, which would have indicated stage 3 disease, 71% of those patients had clearance or elimination of those cancer cells in the lymph nodes at the time of the surgery as a result of the combination of chemotherapy and immunotherapy before surgery. So these drugs can be very effective at increasing the chance of cancer elimination at the time of surgery, reducing the chance of distant metastases, and certainly we think this translates into improved survival and outcomes. So in conclusion, outcomes for patients with lung cancer are improving significantly, not just in stage 1 and stage 2, but across the board with stage 4 lung cancer patients living longer than in previous decades. Immunotherapy agents, targeted therapies, and individualized treatments are really driving the gains in these survival. And we think that the earlier we can treat patients, the earlier we can find them with the screening, the earlier we can treat with early stage disease, the bigger the impact that this is going to have on patients living longer and being cured. Clinical trials are really the underpinning of what it leads to improvement in these cancer treatments, but we need to do more. We need to get more participation in research. 7% is a very low number of patients who are getting access to these cutting edge treatments. And the more participation we have, the more we learn, the more we can gain in the future. And finally, lung cancer is really a complicated disease and requires a team effort. And so it's great to have all of our colleagues who are on this call, but also the other nursing colleagues, pharmacy colleagues, surgery, pulmonary, radiology, pathology, all the key players that are important for allowing us to do the best job that we can do in caring for patients with lung cancer. One last plug here. This is just a list. The text is probably too small to read, but these are clinical trials that we currently have for lung and other thoracic malignancies. Here at UVA, you can see we have a wide range of things from frontline non-small cell lung cancer to second line, EGFR, early stage adjuvant and neoadjuvant trials, stage 3 lung cancer that can't undergo surgery, and a couple of trials in small cell. And you can find this on UVA Health's website as indicated here. So happy to open this up for questions. I'll stop sharing my screen. Right. We've had a lot of questions come in through the Q&A function, and we've been trying to type some answers directly to some of those questions, but I will just open up to the group. We've had a couple of questions submitted prior to today, and some submitted today talking about never smokers who get lung cancer. This is something that's increasingly recognized as something that's really important. It's of interest to patients who get lung cancer who never smoke. What do we know about this disease, and how do we treat it? How do we diagnose it? And is there any role for screening? I'll open it up to anyone who would like to take that one.
I can start with that, but I even throw a question back at you, Ryan. But
Sure.
So yeah, somewhere between 20 and 30% of people diagnosed with lung cancer may have no known history of smoking. And then we start to wonder about these other risk factors. And I think sometimes there just isn't an answer about what caused it, as much as we would love for there to be one. What is interesting and encouraging is that some of the things that you both talked about with these things called driver mutations, or changes in the DNA within the tumor that seem to be pushing that cell into rapid growth and becoming a cancer cell, we seem to have identified more of those driver mutations in people who never were smokers. We still don't know why they have the driver mutations, but we're seeing them. And it turns out that we're getting better and better at finding a perfect match in terms of a treatment for those. I think of it as a lock and key, where we have a treatment that fits exactly with that driver mutation and turns off the switch and lets us stop the cancer growth. So we're getting somewhere in that area, but again, we don't necessarily have an answer to the why. Hopefully we'll keep getting better at that, but I think we are learning more about things like firefighters, indoor pollution, outdoor pollution, radon, things like that. Someone asked if we know which type of cancer or what survival rates are if you have radon exposure. I don't think we know that answer. And we don't know if radon leads to a certain mutation. We just know it can lead to lung cancer. So it's disconcerting, and we're seeing it sometimes in younger people, and there's just no rhyme or reason for it. Hopefully we'll catch up and figure out how to better identify those people who might be at risk so that we can offer screening. But right now we can't really offer screening to the entire population. It just doesn't work out. We would have too many false positives, and it would utilize tremendous healthcare resources with sort of a very, very low yield rate. I know that's an unsatisfying thing to talk about, but it is the way things work in the healthcare system, unfortunately.
Globally, there are some efforts in a few countries. I'm aware of one in Taiwan, where they're taking female never smokers and doing screening, and have found a fairly high, unexpectedly high rate of lung cancer. But as Dr. Martin said, there might be some unique factors, either that's fine particulate air pollution or some other risk factor that is present in Taiwan specifically, and potentially in some other countries in Eastern Asia that we don't quite know. But there aren't a lot of wide population-based screening studies currently ongoing in the US, that take never smokers into account. So
I think there's a common slogan people are saying too: if you have lungs, you can get lung cancer.
yeah, which is absolutely true.
Which is catchy, but it still hasn't translated to us being able to offer screening to everyone. But I do think it hopefully gets us start to think a little bit more about removing the stigma associated with the diagnosis.
Absolutely.
That this idea of somehow blaming the patient, and I just think we really have to get away from that. I'm sure I'm preaching to the choir because of the audience we're attracting today, but yeah, you just have to have lungs to get lung cancer, and hopefully we'll get better at finding out who is more particularly at risk.
And Rick, Linda mentioned something about sort of the adjuvant space, for early stage disease, using the biomarkers and matching therapies with that. What treatments do we currently have for patients with mutations who have surgery? Do we give them the same chemotherapy as everybody else, or do we tailor that?
Well, believe it or not, we often do talk about chemotherapy, especially in a stage 2, 3 patient who undergoes surgery. So if someone has surgical resection, there is a well-established survival benefit to getting post-surgery chemotherapy, though that's usually a lengthy conversation when we have those in clinic. After chemotherapy, there are 2 gene alterations. One was EGFR, and the second is for ALK fusion proteins or ALK gene rearrangements, which only makes up about 3 to maybe 4% of all lung adenocarcinomas, which is a type of non-small cell lung cancer. But EGFR makes up about 15% of that total on average. And so for those 2 specific gene alterations, we often recommend post-surgery and post-chemotherapy, if we do that, oral therapy for 2 to 3 years, depending upon the gene alteration. For some of the less frequent, less common ones, that's not, we like to use studies to prove that there is an improvement in outcomes, and we don't have those yet for some of the rare mutations. So for those 2 specific ones right now, we definitely recommend that. For the others, it's a little more complicated to talk about. But
Great. Just taking a look at the questions that have come in here. And I think we don't have a lot of great answers to some of these, levels of radon exposure that correlate with risk. There are maps that indicate higher levels of radon exposure, but not something that we can really quantify of this much exposure equals this much chance of developing lung cancer. And it's hard to, a lot of times patients have multiple risk factors, and it's hard to pin down whether radon really contributed to that risk. Rick, maybe I'll ask you another question about one that came in advance. You talked about a lot of different drugs with exciting mechanisms of action. One of the other ones we've heard a lot about in recent years is antibody drug conjugates. Are there any antibody drug conjugates we're currently using for lung cancer, and are there any in the pipeline we anticipate using in the future?
Yeah, sure. So one is called trastuzumab deruxtecan. That is quite a mouthful. Also called Enhertu. It's easier to say. That is an antibody drug conjugate that's approved for either if a tumor has a mutation in a gene called HER2 or has a high amount of HER2 on the tumor cell, on the outside of the tumor cell, there's an approval there. There are multiple other antibody drug conjugates, though, in development, both in non-small cell lung cancer, but then also in small cell lung cancer. I can think of just right now off the top of my head, at least 3 or 4 in non-small cell, and then I think I have got 2 in my head for small cell that are in development. So there are quite a few. And the idea and that figure was there's an antibody that is bound to some little chemotherapy molecules, and the antibody delivers these chemotherapy molecules directly to a target cell. The antibodies usually gets inside the cell. It releases the chemotherapy, which then kills the cell. That's the general idea, but there probably are some other mechanisms of how those work that we're still kind of learning about.
Another couple of questions that have come in, talking about genetic, familial risk of lung cancer. Are there any heritable mutations? Does that have implications for screening? I don't know if anyone wants to take that topic.
Well, first, so it's a great question, and one we certainly in the screening space hear a lot about. And I think one thing, just a big take home point, is that these lung cancer screening guidelines in the world of screening are still very new. Even though they've been around for 2013, they were just a starting point, and they are evolving with time. They were just updated in 2022 and then 2023. So each time they try to take in the new research, take in the new literature to frame how those guidelines are going to evolve. So what we currently have is what we currently have, and it doesn't take into consideration familial history of lung cancer. We certainly think there is some associated risk in people with first-degree relatives with lung cancer. So that means your parents or your brothers and sisters, not so much your aunts and uncles and grandparents. So we're hoping that as our guidelines evolve, that that's going to be taken into consideration. And as healthcare consumers, we all can advocate for ourselves, and we can talk to Medicare and we can talk to the USPSTF and suggest that they look at their guidelines sooner. But right now, family history isn't part of the recommended guidelines for Medicare and the USPSTF, who makes all of our national guidelines.
I think we're close to wrapping up, but I just want to add again, trying to inject a little hope here. There's such tremendous innovation happening in lung cancer. I think many of us have been in this field a long time and have never seen so many changes at once. But some of the exciting changes, including improving technologies, not only that might help us screen in different ways, including with blood tests, breath tests, all sorts of things, but also for follow-up after treatment of lung cancer to watch for reoccurrence and things. So there's really all kinds of innovation happening, and I fully expect in the next few years we're going to see better and more techniques for doing both of those things, screening and doing follow-up, that'll help us be more precise, and it may change the spectrum of who we can screen because our testing will be better.
Great.
Great, thanks.
Thank you,
Lynn,
Dr.
for
Martin.
wrapping up
That's
this.
wonderful.
Yeah, certainly. That's why we all do what we do, because we think there's a lot of hope and optimism in lung cancer treatments, and we're trying to improve things as much as we can. So I'd like to thank everyone for all the thoughtful questions, and certainly for all of my colleagues for their talks and wonderful comments. I'll turn it over to Susan to wrap us up here.
Thank you so much to all of our panelists for sharing their time and expertise with us this afternoon. You know, these are very busy clinicians and researchers, and we are very appreciative of their time to share this information about the latest in detection and treatment of lung cancer. You know, I'm always so impressed with the team approach at UVA Health, and I think we saw that this afternoon with these wonderful clinicians. So thank you so much for your time today. Thanks also to my colleagues at the UVA UVA Cancer Center for their partnership as well. I'm just going to share a few things about Lifetime Learning. So thank you so much to the panelists. Please consider, we hope that you will join us for future Lifetime Learning programs. Please consider joining us next Tuesday, November 19th, for a program entitled Americans on the Move. What are the implications for U.S. cities? Demographer Hamilton Lombard and Executive Director Eric Cerconi from the Weldon Cooper Center for Public Service at the University of Virginia will serve on the panel, as well as Suzanne Mumma, who's Associate Professor and Chair of the Urban and Environmental Planning Department at UVA School of Architecture. The panel will explore the impact of recent demographic shifts on communities, housing markets, and emergency and government services. To register for this program and to find out about our programming, visit our website at engagement.virginia.edu/learn. When you get to our website, you can check out future Lifetime Learning programs, the podcast library, our Thoughts from the Lawn blogs, and our UVA Speaks podcast series to read, watch, and listen to our expert UVA faculty. So thank you again for joining us for this hour of learning, and I hope you enjoy the rest of your evening.